Good morning. Can everybody hear me? Your back row, you're good. Okay. Thank you so much for coming today. I'm pleased to be one of the organizers of this conference and so happy to help all of us find more information to help our families and our children get through these tough medical issues that can be so traumatizing for parents just trying to get the help, much less what's going on with your child at all. I'm really happy to introduce Dr. Brian Wise. He's a psychiatrist and lots of other things here at National Jewish and in his own private practice. He's been great at helping me with my children and many, many other children as well. Without further ado, Dr. Wise.
Right. Can everybody hear me okay? Yes. All right, cool. Okay. So first of all, thanks for coming, guys. This is hopefully be a lot of fun and also a great chance to teach some things and also learn from everyone. I've often said that actually one of the best things about being a physician is that I get to learn from my patients. Because they get to teach me a lot, and because there's always more to learn. So just want to give you a little method talk. My background, as Jen mentioned, I'm a psychiatrist, but I do a few other things. Some definitions of function and dysfunction. Some of my frustrations as a doctor as well. Changes and differences between medical, psychiatric, allopathic approaches. And there'll be a number of case studies along the way that will be given very briefly, but just to kind of highlight some things where people came in for psychiatric reasons, but found out that was not really the end of the story. A couple of things to let you know also is that all of the talks, once we gather them up, will be on the website, so please don't worry about taking notes. I know a number of us have a lot of slides, and so we want to make sure that everyone has those available to you. We just may not have them right now, but we will get them and they'll be freely accessible there, okay? So my background, so I grew up in South Carolina, really small town, about 30,000 people. Had tremendous health issues when I was growing up. One time I was told I was about the second or third worst case of eczema they'd ever seen at Duke University. Spent a few summers up there and really had a chance to be on the flip side, being the one taken care of. Essentially, I was allergic to anything that God made. So I don't think anything against me, don't get me wrong, but just everything that was natural I was really at risk to be vulnerable for any kind of eczema, asthma, everything. So due to chronic stress in my system, I didn't grow. So my brother's 6'3", 6'2", and I'm just a little bit south of that. Tiny bit. But later in grad school, when I was at Vanderbilt for a philosophy graduate program, I was determined by one of the pharmaceutical companies to have one of the worst cases of allergies to cockroaches. So they wanted to get more of my blood, so I'm like, if I can make money off cockroaches in grad school, that's awesome. So, but how did I get better? Basically came down to have parents that worked and did everything they could. At one point, a drug was taken off the market, and my mother actually got the head of FDA off of a plane to tell the pharmacist it's okay to let it go and release it to us. I had two doctors that really saved me. Dr. Charles Adams, who retired, but then he ended up seeing me in his home. He just, every few months, I would come to Atlanta to see him. And then Robert Greenblatt, who's here, who was a reproductive endocrinologist. He pioneered Clomid as well as birth control pills. And it's always kind of odd going into his office because there's a bunch of women there. And then there's a small little boy. He's like, we're like, oh, your mom's here? What you doing here for? Like, help me. So I had a chance to have doctors really look outside of the box. And I was really fortunate about that. So a little bit more about functioning. The DSM-5 criteria for our psychiatric disorders talks about functioning in this way. Disturbance causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. And that kind of goes across the board for all the disorders. There has to be some level of dysfunction in order for it to be categorized as a disorder. The World Health Association International Classification of Functioning, they define it in two areas. What activities can you do and how often can you participate? But when you start looking, especially at kids who may have developmental challenges or maybe not neurotypical, often the question is like, well, what's the disorder? What's maybe a medical issue? Or what's just quirkiness? Or what's just personality? And you don't ever want to pathologize that. So really guys, could just be me. I mean, generally speaking, and I know there's going to be some exceptions to this, but if you are seeing a patient and it's not causing significant dysfunction in one of the two definitions prior, I'd be hard pressed to call it a disorder. It may just be an individual being who they are, an individual, and a person without meeting the typical, just like, oh, well, they don't fit inside this box. Well, let's blow up the box then. Not literally, but. So, my tutors. Very well with my patients. My patients teach me so much, and what I don't know, they're happy to show me because I'll be stumped. Like, well, I don't know what exactly is going on. I have the best idea right now, but I will search and I'll walk with you. They bring me new ideas. My first introduction to looking outside of my little psychiatry as dispenser model was that had a patient who was adopted, large history of trauma, it's about 7 or 8 years ago. And he's pretty stable on medications as from a psychiatric standpoint, if you look at what we consider stable. But mom and dad went off, they were between here and DC, and they went off to DC, saw a couple of people. Mom explored some dietary ideas on her own and put him on a gut and psychology syndrome or GAPS diet. Came back to me and they're like, hey, he's doing the best he's ever done. His language skills have taken off. He's much more clear mentally. He is in control of his behaviors. He's much more regulated, not just behavior-wise, but also his sleep cycles and everything. Can we start reducing the meds? I was like, absolutely. So that was really my first introduction to saying, okay, we have to look at other things beyond just what pharmacology will give us. So that spearheaded me to go and do a lot of extra training. So 2014, I got certified by the American Board of Integrative and Holistic Medicine, and then just a few weeks ago got certified in the American Board of Integrative Medicine, which is kind of the higher board level, so there's different areas. And then I've had additional training in integrative medicine and the other domains you see here, like endocrinology, cardiology. It doesn't mean I'm going to be a cardiologist, because that's not what I'm going to do, but just to have the ability to know what kind of things can impact the heart and what kind of things we need to look at, because one of the biggest factors for heart attacks is stress. So, and anger is actually the primary emotion that drives that. So, just be able to put some of the pieces of the puzzle together. Obviously, GI issues, autoimmune, inflammatory disorders, toxins, and as well as some hormones and other more mastocytic activation dysautonomia. So when we talk about like frustration, this is one of the bigger frustrations. The idea of conversion disorder, which essentially the idea is that if you're having medical symptoms that they're coming from a functional or psychological origin, and because nothing's being found on a clinical exam or through lab testing. So these are kind of the things that defines it. You have at least one symptom of altered voluntary motor or sensory function. Clinical findings provide evidence of incompatibility. So the symptom doesn't really match up with the pathophysiology about how things should go. And it's not explained by another medical or mental disorder. This statement of the symptom is not better explained is where a lot of kids and adults will get lost in this, because you'll have this, and a doctor will say, well, we don't find evidence of this, we don't see this, and the labs don't match up what you're reporting, so we don't think it's a medical issue. This is kind of a longer definition of it. I won't go into details, but this is my take on conversion disorder. We just don't know. And doctors have a really hard time saying we don't know. And if we don't know, we're happy to put it into a box that we don't know, which is the brain, because it's too complex. And so this is where I get really frustrated. And this is the ultimate outcome of that, is that it's all in your head. You're given a brick wall to bang your head against. And the problem with it is really, truly, that the workup stops then. Doctors stop looking. Doctors say, oh, you're in the electronic medical record, they're going about, they're doing this, they're seeing, oh, let's check this, oh, conversion disorder. Hey, have you been seeing a psychologist? How about a psychiatrist we referred you to? And things stop. You actually, I've talked to a number of parents who said, you can just see the tone of the appointment change and pivot drastically. And that's just sad. I'm sorry. Because the workup stops. The evaluation stops. The curiosity on the physician's side stops. So, yeah, it's not just in your head. So, I'm going to give a number of examples of cases. So, a very bright, overachieving 15-year-old female referred to me by a pain specialist and a psychologist to complex regional pain syndrome, where there's a pain out of proportion to physical findings, possible conversion disorder. And they thought that maybe that because she's overly perfectionistic, very type A, very highly driven, which is often see that that's kind of the personality or phenotype, if you will, of conversion disorder. And she has high scores on a subscale of testing called somatization, but I don't really know what to make of that, because somatization is why they're coming to you. So why is that abnormal? Why is that like aberrant to say, like, oh, well, you have high somatization? Well, your body is the focus of your perspective, your mindset by then. So, so she comes in, she's on crutches, usually faces her feet down, severe burning neuropathic pain. So I go to her first visit. She's worried about neuropathy, but not excessively so. She's not like just focused and just like, she doesn't have this silo where she's just looking at, oh my God, my nerve pain, my nerve pain. She tends to be perfectionist, but not obsessive. She can let things go. If things don't flow, she has some kids that if they make a 94 on a test are crushed. She's not this gal. Not depressed, not suicidal, no anxiety, no panic, no history of trauma. So I go backwards a little bit more and say, well, what was going on before this happened? And she had her third concussion 4 months prior. Then a month after that, she had multiple infections. So I want to order some labs on her. I ordered a lab called an S100B, which is elevated. S100B is a marker for your blood-brain barrier being disrupted, which means that normally, historically, we would think that the blood-brain barrier is this thing that's completely intact. It's like a cocoon that away from the world. It's fine, it's great, but protected. And we found that that's really not the case. And you can get disruptions through different infections, inflammation, obviously head trauma, concussions. So like I said, this suggests her blood-brain barrier has been compromised. She has a negative Mayo Clinic autoimmune encephalopathy panel, which I think Dr. Clardy is going to talk more about that. So I treat with multiple supplements. We don't really have medications targeting this per se, but that is to reduce the neuroinflammation in your brain, shore up the blood-brain barrier and support her cognitive function. And then 2 months later, she was walking without crutches, significantly reduced pain, and improved cognition. I can't tell you that the supplements I gave her were the difference, honestly, because it may also have been time that her brain can heal on its own. But my idea was that I need to set her up for success and try to reduce the things I can do in terms of inflammation and help get the barrier back intact. Maybe it was a difference, or maybe it just helped her progress a little bit quicker, because especially with this her third concussion, she's more likely to have a prolonged course before she recovers. So how do you detect medical origins? It's almost always a history. It's just about putting pieces together and getting a detailed history. And when I get stumped with a patient, I go back to my initial history and I clarify things I'm not clear about. If I can have this, like, oh, I had this symptom. Oh, well, wait, I didn't go back. When did that start? When did your headache start? When were you sick? When did you have this concussion? When did you have this exposure to X toxin, whatever it is? And that way you can start putting the pieces together and say, okay, we can create a timeline for this is likely to what happened. So that's really the best course. And you can do a bunch of lab work. A lot of the normal labs you get, frankly, are not going to show this. They're just not. Because they're not really designed to show a lot of things that you need to show, like the S100B. It's a pretty rare test, but we found it to be incredibly useful. So the question is, so when to consider non-psychiatric causes? So I'm going through a bunch of different situations, different conditions, but really, I'll come down to a few, but I'll kind of summarize those later. But really looking at personality change, very abrupt change. You're looking at someone who was like a family member, particularly a mother, can say, on this day, everything changed. Multiple symptoms. So you have and a great example of this is like mast cell activation syndrome, where you can have symptoms of rash, you can have symptoms of joint pain, you can have symptoms of different like shortness of breath, you have issues with trouble urinating. There's a whole host of different symptoms that go along with it that don't match up. Like, why is someone having symptoms across every organ system? That doesn't make sense. Non-auditory hallucinations, like visual, smell, or touch, and confusion. Just not being sharp, some people call it brain fog, and you'll see that there's a distinct difference in there. History, there's typically a viral prodrome to a lot of these, not all of the time. There can be severe diarrhea, there can be fever. You need personal family history of autoimmune disorders, so that's where getting an extended history beyond just the patient. Particularly as a psychiatrist, I'm asking about history of depression, history of anxiety, history of schizophrenia, all that stuff, but when I start looking at these kids, I'm looking more medical history as well. I want to know, like, did mom have fibromyalgia? Did this person have multiple sclerosis? Does this person have a history of migraine headaches? What else is going on that genetically potentially leads them for having more vulnerability to any kind of insult? Then there's personal family history of cancer, significant history of tobacco use. That's mostly a sign of vasculitis or inflammation of vessels. The other thing is lack of typical risk factors for psychiatric symptoms. So I've got a patient who she was having psychosis, and she's placed on 3 different antipsychotics. Okay, our meds are not that bad. They should help. But there's absolutely no improvement, and actually got worse on 2 of them. That's a red flag for me, because you should see some movement in the symptoms. And then lack of evidence for any precipitating stress for psychiatric symptom. So like abnormal age of onset, abrupt symptom like we talked about, where it just comes out of nowhere, and this is the day my life changed, and it gets rapidly worse. Treatment resistance, just talked about, and the other thing is, it's not only just treatment resistance, it's being exquisitely sensitive to medications. I mean, like a typical dose of like an antidepressant Prozac could be like 20 milligrams. Somebody can only take like 2.5 milligrams. That could be someone who has something else going on because their brain is inflamed, and that's causing their brain to be a lot more sensitive and intolerant of any higher doses. It doesn't mean you're not going to get benefit from that higher dose. It just means that that's the maximum they can tolerate because of the inflammatory process going on. Unexplained delirium, premature cognitive impairment, issues with memory, amnesia, which most of the time is kind of goes along with that brain fog where you're walking in the kitchen, you're like, why did I come in here? Like, oh, I was in the room, came in. Okay. You walk back to the living room, okay, I was sitting down here and I want an orange juice. Okay, good, okay. Then you kind of go back. Or the person who says, oh, I drove here today, but I have no memory of driving here today. A classic one in kids is loss or regression of previously mastered skills, especially handwriting or mathematical computations, where they could do all kinds of multiplication in their head very quickly, and they're like, and they're struggling. And then like seizures, especially if there's been a family history of seizures or there's been a personal history of seizures. Unexplained stroke-like events where things like the right side of their body goes numb, and you really just like, and you have fairly quick abrupt onset of that, but no findings on an MRI of stroke. Headache, cranial nerve palsies, movement disorders, dystonias, for example, ataxia, and then pain out of proportion to physical findings. And this is also something that you'll find in kids or adults who are diagnosed with this conversion disorder, where it's like, oh, you can't possibly be having that much pain. Yes, you can. It's like, no, you don't understand. This really is an 8 out of 10. Like, no way. No, it can't be. That's because we know everything. Okay. And then there's like central sleep apnea, dysphagia, autonomia, which goes along with like postural orthostatic tachycardic syndrome, POTS. So a couple more cases. 16-year-old male comes in with treatment-resistant depression. He's seen 5 different psychiatrists in our community. He's been to 2 different psychiatric departments. One's Mayo and another one back east. He's literally been on 17 different psychiatric medications. None of them work. He's had numerous ketamine infusions without any benefit. So they come to see me, I review the history, and like, this is not psychiatric. There's no way this is psychiatrically driven. There may be a psychiatric overlay on this, but there's definitely medical neuroimmune issues going on that we need to figure out. So order a bunch of labs. I'm probably known in favor as the psychiatrist that orders the most labs that like LabCorp or best has ever seen, but that's okay. We'll stop and they'll get more blood. But he's got, of like the 14 or 15 immune markers, 8 of them are skewed, and no one checked it. Still trying to figure out what was the driving force for this, and I will unfortunately tell you, so my initial treatment is like, let's get the inflammation under control, let's get some detox going, just because I couldn't find some of the detox, I couldn't find toxins on a detox protocol that some labs are through, but just everything like screamed some. So I started on some very gentle detox in terms of supplements, not any significant IV chelation or anything like that. And I weaned him off as a psych meds because like, what's the point? They're not doing anything for him. So unfortunately, he's not doing great. He's doing a lot better, but he's not where he used to be. But he's leaving in a month to go to college. Whereas previously the concern was well, is he going to finish high school? Is he going to finish this semester? In that case, a 9-year-old female comes to see me 2 years ago. Aggressive, agitated, out of control, tremendous anxiety, can't regulate sleep. They've been worse over the school year. Feels literally, she says, I think I'm cray-cray. She had trial of Celexa, Zoloft by a different psychiatrist. And I thought they were titrated up too quickly, but that's kind of art of medicine. Then she got hospitalized. And the family's told she has bipolar disorder, and then the other part is that the psychiatric team there blames the parents. Like, no, our meds work, so what's going on at home? What's happening there? And this family's awesome. They give her Lamictal, but then the family's like, we're leaving, we're going to take her out because you guys are dumb. Okay, you guys are intellectually compromised. And they come to me with a more natural approach. And so she's actually doing better when I see her. So what's changed? So next 4 or 5 months, after putting her on some supplements, she's getting a lot worse. And to the point where mom actually asked me about ketamine because there's a pediatric bipolar specialist who just came out with a study about ketamine in kids. So I go back to my intake and look at it more deeply with a medical eye. Very sensitive to lights, sounds. She's got really severe abdominal pain, but she's not constipation, not diarrhea. Her bowel movements are great. New onset shortness of breath, and she has no history of asthma. Appetite's up and down. Constipation is really bad, which has never been an issue for her before. So ordered some more labs, and this is one of the labs I got. Transforming growth factor is beta-1. It's a marker for tissue regeneration and remodeling, which means there's some inflammatory process breaking tissue down that she's having to regenerate and reorganize tissue. You don't see this morning. I mean, you can look at, like, let's see, so this is almost up to 6,600, but this is really super high. I mean, normally if I see someone who doesn't have this, they're in like 1,000 maybe, or 1,500. So it's markedly elevated. And then I asked them about mold. They're like, we don't really think so. It's like, okay, that's cool, let's just do it for urine test. And find out that she has a couple mold markers which are highly elevated. I'm not going to go over this long slide, but essentially but this is a mold species that's associated with Fusarium, and it's known to have a lot of toxic effects. But it's immune toxin, genotoxic, toxic to your liver, toxic to the bloodstream. So family gets the home inspected. There's no mold in the home. So then we look back at the timeline. And remember, she was hospitalized in the second semester of school year. She came to see me in July and she was doing better. And that was without medication. And then she got progressively worse. So we're like, hey, come to school.
Yeah.
School vowels and tests, no, it's not us. I have no judgment about that, but they say it's nothing but. However, since that time, there's been 16 kids from that school who've been sick and tested positive for different mold species. Not different mold species, but different immune markers associated with it. As well as a couple of teachers left there because they couldn't make it to work. School, this is not funny, but school district superintendent attends a meeting. I can't say if it's superintendent, but it's someone in the school district system who says, oh, I thought y'all condemned this building. And then 1 month ago, the school announced they had asbestos. So, treatment was to use some binders to help pull out the mold, variety of supplements to kind of help her body, just ability to detox and remove them. And today she's doing awesome. And she's such a doll. She's, like I said, the family's wonderful. I've got a 21-year-old female with symptoms of heat, cold intolerance, and dysregulation. Can't keep her weight up, migraine headaches, psychosis, she hears voices. and some visual hallucinations as well. It says Hashimoto's thyroiditis, which is autoimmune thyroid disorder. And cognitively, she's just always in a fog. She feels, in her own words, ditzy. She feels like she's not really engaged. Feels like she's always like 1 to 2 steps behind mentally. It's kind of like having your like a video you're watching be out of sync with everything, just trying to catch up to the present moment. So she sent to me because she has voices, so I'm supposed to like treat that and give her ADHD meds. She gets really worse prior to me, she'd been on 4 antipsychotics, and they didn't work. They made her worse at really small doses. ADHD meds made her much worse. And she got briefly better with rituximab, which is an immune modulator that one of the other doctors was willing to treat her with because of her Hashimoto's. She gets better with it, but it's short-lived. And so they go back saying, hey, can we get another round for that? The doctor says, I'm not so sure. I mean, I'm glad I helped you, but I don't want to keep just repeating the cycle over and over again. But it tells me there's an immune component to it. So I put her on low-dose naltrexone. Naltrexone is typically used as a medication to help with addictive behaviors, especially alcoholism. And it's at high doses, and when I say high doses, I mean like actual normal, like pharmacological doses. It actually activates your immune system more at really low doses, like 10% of what is normally prescribed. It actually is highly anti-inflammatory. And she really has an overnight change. She was trying to be a trainer, and she had to take her certifications, and she's like, oh, I can't even do one certification over 4 days. I can't stay engaged. I'm constantly slipping and can't stay on task. And a month after being on, she did 8 certifications in 1 day. And then this female, she's 18. She has mastocytosis, which is where your bloodstream has too many mast cells, so it releases too much histamine, and it can really wreak havoc on your body. It's essentially like histaminic cancer. But I see her, she also has dystonia where her joints lock up, and it's really painful, and she gets locked up where at times she can't walk for 3 to 7 days. She had a seizure one day during class in college, and if she's just like 30 minutes late for taking her dose of medication for this dystonia, she locks up, and she's locked up for the entire day. She has nausea and never gets better, chronic abdominal pain, shortness of breath, brain fog, hives, horrid anxiety. She's just a mess. I mean, she's got a lot of stuff going on. But she and her family, again, I mean, they're great folks. They're willing to do whatever it takes to help. And so they're willing to just say, like, let's keep trying. And so they've got a great attitude. And then she is on some medications for her mastocytosis, as well as her dystonia. Serpentine is there to try to help her appetite, but it's not really working. Gabapentin is there for pain. So I have her on a few supplements to start with. So I see her right about a year ago. I actually saw her on July 20th, and she said, oh, I'm doing really well, this is great. And I was like, okay. No, I'm sorry, it's small. I saw her like the week before that, like around 13th or 14th, saying she was doing well. She texted me saying, yeah, I'm not doing great. Can you see me? And she's struggling. She's unable to function at school. She's going off to college to be a music major. And she's there on scholarship. And she's there, and she can probably participate in music the way she can, probably like 10 to 15% of the time maybe. And the rest of the time, she's nowhere near her capability. there's one day that a professor looks at her and says, "You nailed that. That's great. That's who we have always wanted here. That's the person." She's like, "Yay!" But that means I'm taking a spot as someone else who could be here, and that means I'm not the person I should be every other time. And she has tremendous guilt about this. And she has to walk around college when she's locked up like in braces. Tremendous low self-esteem. I mean, she should be in the prime of her life. She's like 19, 20. She should be like thriving. But she's not. So she asked me about putting her own antidepressant, but here's the thing about mastocytosis and mast cell is that the mast cells release histamine, but they also release a lot of serotonin. So if you give antidepressant with serotonin, then a lot of times people will get worse because they have too much serotonin in their system, and they'll get flooded, and they will get a lot of physical symptoms and be overloaded. She actually did a supplement of 5-HTP, which is a precursor to serotonin. At the lowest, it's like 50 milligrams, and she was bedridden for like 2 days. So I was like, we're not going to go towards antidepressant. Probably not the best way to go. So let's look at some different options. So, let's see. Yeah. Okay. So, I started with taurine, which can help with anxiety. So it's really low energy, dystonia. But then we talked more about her nutrition, because we know that she can't eat very well. She's got nausea all the time. So, but her BMI is 15.7. And she does not have an eating disorder. That's a sidebar, is that I've seen kids with this kind of disorder that go to medical and they get diagnosed with an eating disorder, even though it's not a purposeful or psychologically driven eating disorder. It's simply they can't eat because it hurts them all the time to eat. So she's 5'7", weighs 100 pounds. The superpeptidine, which I mentioned earlier, is not helping with her appetite. So we do a much more detailed amino acid profile and nutritional profile. And so there's supposed to be like an image there. Okay. Okay, so I'll tell you what it says. So it goes through about 22 amino acids, and what happens is that all of them show a huge nutritional need. Generally, if you see some of the amino acids, you can see like maybe like 100 milligrams or like some. Oh, okay. Thanks. But she has huge needs across her entire amino acid profile. So, okay. So she also has some mercury toxicity, and she has some tin because she eats tuna out of can all the time. So treatment recommendations, sodium alginate, which you have to order it online, but it helps great. It helps gut better than anything else we have. High dose amino acids. Polyphenolethanolamine is it's a really complicated nutritional supplement, but it helps on so many different levels in terms of helping reduce inflammation. It helps stabilize mast cells. It helps with chronic pain. It helps with mood and anxiety. So it's not serotonin based. Actually helps activate your endocannabinoid system. And so we're going to talk about removing fish because of the mercury. I see her nausea is completely gone. She used to eat this like 1-inch wedge of lasagna, and she was like, ugh, I'm too bloated. Now she has like a 5-inch wedge. She's like, yes, I can eat. She actually, one of the biggest things for her, we go back to like function and dysfunction. One of the things that was such an issue for her was that if she missed one of her doses of her dystonia medication, 30 minutes later she'd be locked up. She actually went 6.5 hours without locking up when she missed a dose. It wasn't on purpose, she just missed it and didn't notice it. And she felt so freed up about that. And she did have one dystonic reaction during that month between appointments, But she was back on her feet making tea with the family half hour later. So let's see, on interest of time, we have, one thing I'll say is she was starting to have some mood issues come back. Felt like she's kind of plateaued. So I added a low dose of lithium. By the way, dose of lithium for like bipolar disorder would be like 900 to 1500 milligrams. Had her on 150 milligrams because it's actually highly anti-inflammatory. And then she feels great, much better. Add in some detox issues, and then her mood really just sunk. I'm like, what happened? And this is a benefit where being a psychiatrist, I can get into all that detail about, well, what's going on? And found out that she was holding her aunt's baby, who was a newborn. She's like so thrilled, like completely blissful. And then she gets this image in her head of a doctor telling her she's not going to be able to become pregnant. And she's just crushed. So I tell her doctors are not always the smartest people in the world. So I told her this is what's going to happen. You're going to go to a high-risk OB doctor who can talk to her about ways of mitigating her risk and trying to help in terms of here's what you need to do, here's the risk, what's acceptable to you and what's not. And you'll work it out. So continue to pop out lithium a little bit. And so I was giving this talk, I'm just giving a separate talk on mast cell activation syndrome. So I text her like, hey, what's up? How's things going? And then in our last minute, those were words. So the point of this is not that I'm a hero, okay? Not. The point is to look outside the box you're given. Get out of your silo of, I'm a GI doctor, I'm a neurologist, I'm this. Get your head out of the sand, please, and look around and say, there may be other things I'm missing. And please, if you're able to do that, that's great. If you are taking kids to someone and they're kind of stuck, try to get someone who can get a bigger, broader perspective, a viewpoint, and come at it from different angles, right? Thank you.